Welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for joining us today for Mgen, Unmasking the Stealthy STI during Sexual Health Month, a non-CME program of our Dr. John G. Bartlett Memorial Education Series, and special thanks to our webinar sponsor, Hologic. Before I turn the program over to our host and moderator, a few housekeeping matters. This webinar is being recorded and will be available on demand if you cannot stay for the entire presentation. A link will be emailed to all registrants within 3 business days of today, or you can access it and share it via our website and the IDSA YouTube channel. You'll notice that your microphones are muted, but please use the Q&A feature at the bottom of the screen to ask questions during the event. There will be a dedicated Q&A session at the end of the presentations. If we can't get to all of the questions today, we'll do our best to address them in a follow-up email. Now I'm pleased to introduce Dr. Rupa Patel, who holds the position of Research Associate Research Associate Professor Voluntary at the Division of Infectious Diseases, Washington University School of Medicine. Dr. Patel.
Thank you, Diane. I'm a practicing infectious diseases physician in a sexual health clinic in Washington, D.C., and affiliated with WashU in St. Louis. We have an exciting webinar today. It's case-based and practical for the busy physicians practicing in infectious diseases clinics, as well as clinician educators. And it's wonderful that the IDSA Foundation brought this topic of Mycoplasma genitalium. Today, we're going to cover the epidemiology and the impact, the treatment and diagnosis, as well as, very importantly, the complications of untreated Mycoplasma genitalium. And we have 2 renowned speakers today. It is my great pleasure to introduce Irene Stafford. She started her educational career with a Master of Science in Microbiology. She went on to complete a residency in obstetrics and gynecology at Louisiana State University. Her interest in perinatal medicine led to a completion of a fellowship in maternal fetal medicine at the University of Texas Southwestern. She's a core member of the Texas State Congenital Syphilis and HIV Review Board. She's been awarded several grants in the field of congenital syphilis and Mycoplasma genitalium, and she enjoys spending time with the medical students, residents, and fellows at the UT Health Science Center, where she is an associate professor and associate program director for the Maternal Fetal Medicine Fellowship. And our second speaker is Dr. William Geisler. He is a professor of medicine and epidemiology in the Division of Infectious Diseases at the University of Alabama at Birmingham, UAB. He is an internationally recognized expert on chlamydia and Mycoplasma genitalium infections, has conducted epidemiological, clinical, and basic science research on these infections. He has over 20 years of clinical experience in the evaluation and management of STDs, and provides education and training through the Southeast STD HIV Prevention Training Center, or the PTC. He is on the editorial board of STDs and has served as an expert consultant for CDC and WHO. He is also the director of the UAB STD program, research director of the UAB Diagnostics Mycoplasma Laboratory, and the UAB Assistant Dean for Physician Scientist Development. So before we get started, I want to remind the audience to put their questions in the Q&A feature instead of the chat, and I'll turn it over to Dr. Dr. Stafford.
Good afternoon, everyone. It's an absolute pleasure to be here today. Next slide. I'm excited to talk to you about Mycoplasma genitalium. I have no disclosures, no conflicts of interest to disclose. These are Dr. Geisler's disclosures. Next slide. So let's talk about Mycoplasma genitalium. So Mgen, as it's known, is a sexually transmitted infection. It's a small pathogenic bacteria, and it affects the mucosal epithelial cells of the genitourinary tract in humans. It has one of the smallest genomes of any known self-replicating organism. In fact, it has 525 genes and 1 circular DNA of 580,000 or so base pairs. Mgen does not have a cell wall, so it's not gram-stainable, and most of our traditional antibiotics like beta-lactams don't actually work against this organism. Next slide. So what is known about Mgen? Well, to be honest, it's not a reportable infection. So most of what we know about Mgen is from studies done by investigators like ourselves. An NHANES study from 2018 by Lizzie Terone at the CDC showed that the prevalence rate is about 1.7 among people aged 14 to 59 years old in the United States. Multi-site recent studies showed that in STI clinic attendees, the prevalence rate is a little bit higher, approximating about 16%. It is more common in young people between 15 and 24 years old, and it's higher, like most STI, it disproportionately affects Black, non-Hispanic populations. It is highest in patients or people with other STIs. So you see there that the prevalence ratio was 1.7 for co-infection with chlamydia. In other words, people who are infected with chlamydia are more likely to be co-infected with Mycoplasma genitalium. Next slide. So this is just a summary of some of the nice prevalence studies that have been done in the past. As you can see there on the far left, Dr. Getman had a prevalence study that showed that it's about 16% in women and 17% in men. And again, these are STI clinic attendees. You can see with Dr. Munson's work, he unfortunately gets the prize for highest prevalence of Mgen, where it approximates 24% in Wisconsin area. You can see that other prevalence studies have been done. And on the far right there, you can see in a low-risk pregnant cohort, I was able to figure that the prevalence rate in a low-risk population, it was about 6% in pregnant women. Next slide. So what does M. genitalium look like? What are the signs and symptoms of infection? Well, Mgen infection can produce a different variety of actual symptoms. It can also be asymptomatic. In men, it's about 9% that positive in men that are asymptomatic. For men, the most common symptom is urethritis. It's in fact responsible for 26% of non-gonococcal urethritis in men, okay? 26% of men who have sex with men can have asymptomatic or symptomatic rectal infections, and it also has been found in the pharynx. Next slide. What about for women? So women can have another, a completely different array of symptoms and findings. They can have vaginal discharge, cervicitis, and dysuria. Okay, so it's really important when people present for UTI symptoms to take a good sexual health history to know, could this be Mycoplasma genitalium? It could also present with pelvic pain and cramping. So there you can see under females is a list of different symptoms that a female patient can have when they're infected with Mycoplasma genitalium. For example, vaginitis, 21%, cervicitis, 11%, PID, pelvic inflammatory disease, super important at about 15.4%. And again, similar to males, they can have symptomatic or asymptomatic rectal infection. Next slide. So M. genitalium is linked to adverse outcomes in women due to genital tract pathology, not only pregnant, but non-pregnant. So we could see there in the pregnant population, it has been linked to miscarriage, preterm birth, and in non-pregnant individuals, it could lead to tubal infertility and resulting from pelvic inflammatory disease. Next slide. So this was a really excellent study that I think is just one of the biggest landmark studies with regard to Mycoplasma genitalium. And we could see that Dr. List and colleagues showed that M. genitalium is associated with pelvic inflammatory disease. You could see there that the pooled odds ratio is 2.14 for this organ is being associated with PID. Next slide. You can also see that M. genitalium is associated with miscarriage or spontaneous abortion. You could see there that the odds ratio was 1.8, that Mgen is associated with this adverse pregnancy outcome. Next slide. With regard to preterm birth, and this is really important, especially in my field of obstetrics, when we look at the risk of M. genitalium in preterm birth, we could see that the odds ratio was over 2.3, that M. genitalium is associated with preterm birth. Next slide. So this was just a recent meta-analysis with summary points, and this was done by Dr. Harold Weisenfeld in 2017. And this shows exactly the same thing, if not more so than what Dr. Liss in her study showed, which we could see that M. genitalium, even after you exclude 2 studies that use only serology, that M. genitalium was in fact associated with PID with an odds ratio of 2.7. And again, when you control for other STI, the preterm birth rate was 1.9, which is still very high. And with infertility, even if you control for gonorrhea and chlamydia, the rates of infertility associated with Mgen was 3.43. Next slide. So what about M. genitalium in pregnancy? So when we look at different regions of the United States, there was a prevalence rate of 16% in patients in the Northwest region of the United States. And what this study showed from Dr. Perrin and her colleagues was that preterm birth was higher in women with M. genitalium detected in the third trimester compared to women without M. genitalium. And this is after adjusting for significant covariables like age, race, education, and other STIs. And look, it's a similar STI as Dr. Liss with an odds ratio of 2.3. Other studies have linked these molecules to preterm premature rupture of membranes, chorioamnionitis, and adverse neonatal outcomes, including NICU admissions, where babies went to NICU even if they had no other issues. And in these pregnancies, the prevalence rate was 34%. So almost double what we see in pregnancies that don't have these complications. Next slide. So what about low-risk pregnancies? So we were fortunate enough to do a study where we looked at over 700 patients. So we found that prevalence rates in low-risk Hispanic Latina women was 6%. But what we did find is that it is still similar to other STI. It's more prevalent in pregnant women that are young, that are Black, and that are co-infected with other STI, similar to chlamydia. The macrolide resistance rate in this study was 31%. Next slide. So what about in high-risk pregnancy? So we are doing an ongoing prospective study at UT in Houston, where we're looking to see what the role of M. genitalium is in patients with these pregnancy complications to see if M. genitalium is linked to recurrent adverse pregnancy outcomes. So our population is people with prior preterm birth, prior current cervical insufficiency, prior miscarriage, and prior fetal demise. So we're testing these women in pregnancy to see if M. genitalium is associated with an increased risk of recurrent adverse pregnancy outcomes. Next slide. And here, this is interesting. So the M. genitalium, the prevalence of M. genitalium in this study so far is 11%. And granted, we're almost halfway done now. We're at almost over 200 patients that have been enrolled, but the prevalence was almost double compared to the low-risk population. And what we found is the macrolide resistance in this study was significant at 47%. And Dr. Geiser is going to talk more about this problem regarding macrolide resistance in M. genitalium strains. And again, similar to what we found in the low-risk population and what other epi studies have shown is that it's more prevalent in pregnant women that are young, that are Black, and among women that are co-infected with other STI. Next slide. So what we thought would be another interesting question, and since we had this population and enrolling these patients, we want to know what is the basic knowledge that patients have about M. genitalium? I mean, most of my patients that I ask are completely unsure about this organism. And we also wanted to ask these patients if they were interested in getting tested for M. genitalium during pregnancy. Even if there is no, right now, there's very limited options in terms of treatment. And then we wanted to ask these patients what their preference for screening was, whether it was self-swab or physician swab. Next slide. So this is kind of neat. So in the 126 patients that we enrolled, 98% of our pregnant individuals had not previously heard of Mycoplasma genitalium. 74%, which is really surprising to me, they wanted to be tested. People want to be tested for STI, okay? And they wanted to be tested regardless of the fact there was limited treatment options in pregnancy. Not surprising, most women wanted to be screened via self-swab compared to physician assisted collection, so 60%. Next slide. So this is just a figure that showed that women preferred to self-swab, even when it's pregnant, and it's a little bit harder in the third trimester. Patients preferred that method of testing. Next slide. So I think it's really, really important to talk about the association of M. genitalium and HIV infection. To begin with, we know that M. genitalium is associated with HIV viral shedding. In population studies that looked at males and females that use PrEP, there was almost, in males especially, there was a twofold increased risk of Mycoplasma genitalium infection in males that use PrEP compared to those that did not in STI clinic attendees. When we look at the association of MGen and HIV in women, this to me is astonishing that the rates of MGen are fourfold higher in women with HIV. A large meta-analysis, and again, a lot of these studies are global, but there was a large meta-analysis for 32 studies that showed that HIV acquisition risk increased, obviously among females infected with any STI. However, the greatest effect was among females infected with MGen. Next slide. So I think the best way to talk about Mycoplasma genitalium and how it plays into our lives as clinicians is by presenting a case. So a patient presents to her OBGYN with complaints of vaginal discharge. She's been with 2 partners in the last year and reports no other symptoms. She was last seen by you a year ago and she was tested for STIs, including syphilis, okay, and HIV, according to the CDC STI guideline recommendations. A sterile speculum exam was performed and there was light yellow tinged vaginal discharge noted. Next slide. So she was tested for gonorrhea and chlamydia and was told at the end of her visit that her results will be available soon. The test for gonorrhea and chlamydia returned as negative. She goes home and she reads about MGen on Dr. Google. And she wants to go back to her doctor to discuss whether or not she should be tested for it. So the question is, should she be tested for Mycoplasma genitalium? So here, I'm going to turn it over to Dr. Will Geisler. So Dr. Geisler, please take it away.
Thank you so much, Dr. Stafford. And I just want to quickly mention that I'm really appreciated to be given this opportunity to speak at this Dr. Bartlett Memorial Education Series. I had the opportunity to hear Dr. Bartlett speak at multiple meetings, and he's really an exceptional educator. So Dr. Stafford just kind of went through the clinical significance, the epidemiology, and some other risk factors for genitalium, and then kind of led in with this case. And I'd like to go to the next slide. What I really would like to do is talk to you about detection, testing recommendations, and how we manage genitalium. And then once I talk about this, we'll go back to that case to kind of walk through to tell you what happened, how that kind of agrees or disagrees with what's recommended, and then we'll kind of close it out from there. And so let's first talk about detecting genitalium. How do you do it? Well, unlike a lot of bacteria, genitalium is quite difficult to culture. It takes several weeks to sometimes months to grow it, and it requires specialized media and really just expertise in those performing it. So there's only a handful of labs that do it in the world, including ours here at UAB. And so we don't use culture for detecting genitalium in clinical care. What's recommended and what we use is a nucleic acid amplification test, or NAT, such as a PCR-based test. That's what's recommended. And there are actually 3 FDA-cleared genitalium NATs in this country. They're all very sensitive tests and very specific. But what none of them have is they don't have resistance markers for genitalium as part of their test, which is kind of makes it challenging in management of genitalium, which we'll talk about later. As far as the types of specimens that you collect for genital infection, in men, what's recommended is first catch urine. So the male starts to pee directly into the cup. That's the specimen that you want. And in women, it's a vaginal swab, whether it's self-collected or clinician collected. Next slide. And so, but who should you test for genitalium? Keep in mind, as Dr. Stafford mentioned, that many individuals with genitalium are asymptomatic. However, some have a variety of clinical syndromes at the site of infection. And so what the CDC recommends as far as genitalium testing in their latest 2021 STI guidelines is that MGen testing should be performed for those with persistent or recurrent urethritis or cervicitis, and that you should consider doing it at the initial presentation of women with PID. There's no discussion in the guidelines about whether you should do MGen testing for women with vaginal discharge, such as this case that Dr. Stafford began to present. So it makes it a little bit challenging. And a lot of times women don't get pelvic exams with speculums, and so you may not know whether they have cervicitis or not. Vaginal discharge could actually represent cervicitis in those women, and there's simply no guidance about whether to test those women with vaginal discharge. But the CDC does come out clearly and say that routine MGen screening in asymptomatic persons, whether they're male or female, or whether they're pregnant or not, is not recommended. And so even though it's an STI, you would think, right, you should just test for it, right? The problem is we simply don't have the natural history data for untreated asymptomatic infections to understand, do they cause complications or not? Because we have very limited treatment options for genitalium, and there's resistance concerns. So it doesn't quite make sense to test asymptomatic people, try to treat them when you might just drive more resistance, and treatment may not make an impact on what happens with that infection and complications. Next slide. As far as if you have an individual that tests positive for genitalium, however, how do you treat it? Well, there's 2 major considerations you need to think about. First is whether antimicrobial resistance is an issue. And the second is, because we have such a limited number of treatments for genitalium, what would be the best treatment strategies to treat these patients? Next slide. And so unfortunately, as Dr. Stafford mentioned, genitalium doesn't have a cell wall. And so the beta-lactams simply don't work against this organism. And there are other classes that don't work as well. And frankly, there are really only 3 major classes of antibiotics that we have available in the US where we have published efficacy data to say that it may work. Those 3 drug classes are your quinolones, particularly moxifloxacin, your macrolides, particularly azithromycin, and your tetracyclines, either doxycycline or minocycline. The other drug classes I've listed here are ones where we either don't have data available to know if it's going to work against genitalium, or you simply cannot get them in the US. Next slide. So let's talk about how well these 3 drug classes work against genitalium. Let's go from the worst to the best. Starting with the worst is doxycycline. doxycycline has very low cure rates against M. genitalium, typically less than 50% in men and women. And what's interesting is when we have been able to grow up the strains in people who have failed treatment, they don't appear to have resistance to doxycycline, at least that we can tell in growing them up. But they just don't respond in terms of cure. But what doxycycline does do is that it can lower the M. genitalium load. And because it can lower the load, that does give it a role in different MGent treatment strategies. But I will say that we don't exactly culture a lot of M. genitalium strains. And we have actually been following one patient here at UAB that now we have a M. genitalium strain that's a tetracycline resistant M. genitalium strain. And he does have elevated MICs to both doxycycline and minocycline as well. He's an immunocompromised patient that has failed multiple treatments. He's still infected at this time, and he'd gotten multiple rounds of doxycycline as part of the different treatments. And so we are concerned about increasing MICs and decreasing effectiveness of doxycycline against MGent in the future. Next slide. So macrolides are what we really use to treat M. genitalium since we've known about it, with azithromycin being the one by far that we had the most clinical experience with. However, unfortunately, in the last 10 to 15 years, we've seen emergence of macrolide resistance mutations, specifically in the 23S rRNA gene. And so you cannot, again, you cannot usually grow these strains. So the way that we're measuring resistance is we're doing genotyping. We're looking at specific mutations in the genes themselves. And when you have these 23S rRNA gene mutations, you have very high macrolide treatment failure rates over 80%. And so what that means is that macrolides are really no longer going to be a good empiric treatment choice for M. genitalium when you have such poor outcomes with patients who have macrolide resistance. And macrolide resistance is very common, as I'll show you in the next slide in a second. The other thing I want to mention is that the reason we've got to this point with emergence of macrolide resistance in M. genitalium is in part because the organism grows very, very, very slowly. It also has a biofilm, so that, slow growth in a biofilm increased risk for resistance development. But also, it's because we use so much azithromycin in the U.S. We use it frequently for treating STIs and STI syndromes, but we also use it for literally most other infections, and it's the second most prescribed antibiotic in the U.S., the Z-Pak is. And so better antibiotic stewardship could help to preserve some of the macrolide sensitivity that's still remaining within genitalium. Next slide. So as far as how common the M. genitalium strains are that have the macrolide resistance mutations, you can see different studies published from the US here in this map. And overall, the prevalence of these macrolide resistance markers ranges from about 31% to 94% of M. genitalium infections. Highest rates are in MSM, such as a study out of Seattle. 94% of MSM with MGent had a macrolide resistant strain. In Birmingham, we published a study where 74% of HIV positive MSM had a macrolide resistant MGent strain. The lowest prevalence of macrolide resistance is in pregnant women. Dr. Stafford published a study, 31% macrolide resistance in pregnant women. We published a study in Birmingham where it was 44% macrolide resistance in pregnant women. But all in all, I think the point I want you to take out of this is that macrolide resistance is common. It's been going up every year that we've been tracking it. And it's to the point where probably half or more patients are probably going to have a macrolide resistant strain, and therefore azithromycin is not going to be a good empiric antibiotic to use. Next slide. This just gives you an idea historically. If you look at, these are different treatment studies for M. genitalium where they've used azithromycin 1 gram, which is a standard dose used for STIs. Studies conducted prior to 2009, about 85% of people on average were cured with M. genitalium when they got azithromycin. Since 2009 studies, the overall cure rate's about 67%. The most recent clinical trial that was done in men with NGU, the cure rate was just under 50% with azithromycin for M. genitalium. So really, if we don't get the azithromycin use turned around, we're going to have most of these strains in the near future resistant to macrolides. Next slide. So that really leaves us with just the third drug class I mentioned, which are the quinolones. These are really the best treatment we have right now is to use a quinolone. And we definitely see mutations with M. genitalium to different quinolone resistance determining regions, particularly the PAR-C gene. However, just because you have a resistance mutation doesn't mean you are going to fail treatment, which is where it's quite different than macrolide resistance, where usually you'll fail treatment. But in the case of quinolone resistance, it kind of depends on which mutation that you have. And so there's one mutation that's been pretty strongly associated with treatment failure in the literature, and that's a mutation in the PAR-C gene, specifically the S83I mutation. When you have that mutation, it's been shown that over 50%, closer to really 60% of people with genitalium in that mutation are going to fail treatment. There was a study just published this year, actually, that showed that on top of having that one PAR-C mutation, if you also have a mutation in the GYR-A gene, then you have an even increased risk, higher than 60 or so percent for treatment failure versus if you had the S83I SNP alone. So with both the GYR-A and the PAR-C mutations that I mentioned, the treatment failure rate's closer to 80%. And so that's quite concerning. There have not been many studies in terms of how prevalent these quinolone-resistant PAR-C mutations are in the US, but in the few studies published, the range is about 6% to close to 30%, of course, higher quinolone resistance in MSM. And what's really concerning is most studies have shown that when you have that PAR-C quinolone resistance mutation, you typically also have the macrolide resistance mutation as well. So you have a multi-drug resistant strain, and basically you don't have great treatment options at that point. Once you have a strain that's resistant to quinolones and macrolides, you're going to have a good chance of failing treatment. Next slide. This slide shows you historically the cure rates of moxifloxacin given anywhere from 7 to 14 days for genitalium. Studies done prior to about 10 years ago, almost 100% of patients were going to be cured. Now, in the last 10 or so years, we've seen cure rates in the 60s to 80s percentile range. And that is because of the emergence of these PAR-C resistance mutations and more people failing treatment. And I'm sure part of it also is once you have a resistant strain and you're in a high-risk population that spreads that strain, it's just going to continue to be an issue. Next slide. So hopefully you appreciate the importance of resistance development for genitalium. And because of that, we really do need some type of national surveillance program for this. So there is no federally supported surveillance program for genitalium. However, Hologic has been very fortunate to support a pilot Mycoplasma genitalium surveillance program that's been going on since 2020. And there are basically 7 different STD clinics in the country. One is here in Birmingham, but the other ones are listed there. It's Denver, Greensboro, Indianapolis, New York City, St. Louis, and Seattle, University of Washington. So this is a study being done where at each of these different sites, there are about 800 specimens collected from men and women each year. Those specimens get sent to the coordinating center, University of Washington, where Lisa Manhart is leading the study. And they do the testing for genitalium and for resistance markers. We just published a study in Clinical Infectious Diseases about 2 months ago based on the 2020 data. And I'm not going to go through all this data. I just want to make you aware that there is a surveillance program. You'll see publications come out every year or two or so with the surveillance program. Our hope is that this will be picked up on a federal level because I do think we need to monitor resistance trends for genitalium. Next slide. So ultimately, because we have such limited treatment options and because we have resistance concerns, we need novel strategies to treat genitalium with the limited treatment options we have. And so one of these novel strategies proposed is called resistance-guided sequential treatment. The way that it works is when a patient first comes in with some type of clinical syndrome consistent with genitalium, you would want to basically go ahead and test them at that first visit for genitalium, which I know goes against kind of the CDC guidelines to wait till it's recurrent persistent, but you really need to test them at the first visit. And then you need to go ahead and give them empiric treatment for that clinical syndrome, which is likely going to be 7 days of doxycycline. And then basically around the time that the 7 days of doxycycline are done, you should have the Mgen test results back. And if you have access to testing for macrolide resistance, if they're Mgen positive and they do not have macrolide resistance, then what's recommended after finishing that 7 days of doxy is that you give them an extended azithromycin treatment regimen, not just the 1 gram on day 1, but after that, you want to give them 500 milligrams a day for the next 3 days. So a total of 4 days of treatment, a total of 2,500 milligrams treatment. And the reason why we do the extended regimen instead of the single dose is because the organism is so slow going and it has a biofilm, the longer therapy will help to limit resistance development, and that has been shown in studies. But if in the sequential approach, if you have an Mgen strain that has a macrolide resistance marker, then after the 7 days of doxy, you would follow that with 7 days of a quinolone. In the US, that would be moxifloxacin. Outside the US, some have access to a quinolone called citalfloxacin. Either of those would work. So the doxycycline for 7 days is simply to lower the Mgen load so that then the second antibiotic, either azithromycin or moxifloxacin, would have a better chance of curing the patient and not developing resistance on that second treatment. Next slide. And so this sequential treatment strategy has been tested in 2 different studies that are published, both out of Australia. Both studies included men and women. And in both studies, the frequency of macrolide resistance markers in their populations was close to about 70%. So in both studies, for patients with Mgen who did not have a macrolide resistance marker and got the sequential approach of doxy followed by extended azithromycin, 95% were cured with that strategy in both studies. For the patients in both studies who did have macrolide resistance markers, so they got doxy followed by a quinolone, either moxifloxacin or citalfloxacin, the cure rate was 92%. So the fact that both of these studies had cure rates over 90%, that is better than what other studies have showed in terms of monotherapy. However, neither of these studies did direct comparison to monotherapy, which was, I think, a major limitation of these studies. But I do think this evidence is strong enough that it makes sense that we should be doing sequential treatment strategy right now until we have better treatments. Next slide. And so in terms of the guidelines, the CDC guidelines, as well as really the other major guidelines out there in the world, do recommend this sequential treatment approach. And the CDC guidelines, they recognize that the FDA tests don't have macrolide resistance markers. In fact, there are very few labs in the whole country that actually do that testing. We do it at UAB. You can always send it to our lab. But the CDC recognizes that most people don't have access to that resistance testing. So what they recommend is that if you suspect genitalium in a non-pregnant person, then you empirically give them the doxycycline for 7 days, followed by the moxifloxacin for 7 days. That the resistance markers for macrolides are just too frequent for you to empirically give them a macrolide just because of the chance that they'll likely fail the treatment. And so that's what they recommend. But if you do have a macrolide resistance marker test that you have access to, and a patient does not have a macrolide resistance marker, then they do want you to give azithromycin extended regimen after giving the 7 days of doxycycline. Next slide. So what do you do for these patients with these multi-drug resistant strains who have failed azithromycin and moxifloxacin? Well, first, I always recommend that you confirm they still have persisting genitalium treatment before you try a salvage treatment, because sometimes patients have persisting symptoms, but it may be from other causes or just residual symptoms that haven't gone away yet. And so, but if you've confirmed persisting genitalium and they've failed other treatment regimens that are recommended, then this slide here basically summarizes 4 possible salvage treatment regimens in the US. I'm calling them salvage treatment because basically none of them have strong data supporting that they would work against genitalium. But of these 4, the one that I would usually recommend is going to be minocycline. Minocycline is a very old tetracycline. It's cheap. It's well tolerated. What's recommended for genitalium is that you take it 100 milligrams twice a day for 14 days. And in one published study, and I think it's maybe 30 to 40 patients who was treated with minocycline, 71% were cured that had Mgen. And then there's been a couple of other case reports showing that it did cure these patients. And so we've had pretty good luck using minocycline as our first treatment regimen for salvage treatment. If they fail minocycline or they can't tolerate it, there is another newer tetracycline called a metacycline that you give 2 tablets once a day. We would have no idea how long to treat Mgen, but it would be at least 7 days or longer. It's a newer tetracycline. It's got very broad spectrum activity. In vitro in culture, it works very well against tetracycline, that tetracycline resistant strain that I mentioned. And just in general, it has good MICs against tetracycline drugs. The problem is there's simply no published clinical efficacy data in humans. So we don't know if it actually works, and it's very expensive. And it's simply just not been studied for it. It is FDA approved for other indications, but not for genitalium treatment. There's another antibiotic called lefamulin or lefamulin, depending upon how you pronounce it. It's given once a day as well. And again, there's no recommendation how long you would use the treatment, but at least 7 days. It's from a completely newer drug class called pleuromutilins. It is FDA approved for pneumonia, but not for M. genitalium. It has good in vitro activity in culture against multi-drug resistant Mgen strains. But again, like omadacycline, lefamulin has no published efficacy data, and it's very expensive as well. Lastly, the nitroimidazoles, specifically tinidazole, which if you're not familiar with nitramidazole class, that's the class that has metronidazole, or flagyl is in that class. But within that class, tinidazole turns out is the drug that had the best in vitro activity against M. genitalium, and it does have pretty decent in vitro activity. But there's simply no published efficacy data to know if it would even work. We usually use that to treat protozoa or anaerobic bacteria. So I do have some concerns about trying tinidazole, but because there is some in vitro data, I just wanted to mention that as a possibility. Next slide. I want to take this quick opportunity just to remind you that Mgen treatment in pregnancy, that other than the macrolides, all those other drugs I mentioned, the tetracyclines, quinolones, and lefamulin, they're all contraindicated in pregnancy. And so you can imagine we really have a big problem trying to treat pregnant women in the US that have Mgen, because pretty soon the majority are going to have macrolide-resistant strains, and most are going to fail azithromycin. And we're going to have no other treatment options other than just basically to monitor them during pregnancy. There is a drug called pristinomycin. It's a streptogramin. It is available outside the US. Specifically, it's made in France. And so that's one place you can get it. It is safe in pregnancy, and it does have published efficacy data showing that it cures the majority of Mgen infections. However, you simply cannot get it in the US. I did get it for this one patient I mentioned that has that tetracycline-resistant strain. It took several weeks to get it. I had to get FDA clearance. I had to get clearance from the company. I had to get IRB approval. It was a very laborious process. This patient failed this treatment anyway, but I don't think you're going to get access to this drug because it's just difficult to get into this country. I'm currently talking with some individuals at the higher level to see if there's any way we could get a mechanism to import this in the US for pregnant women. So stay tuned on that matter. Next slide. And then as far as partners, you just test the partner first to see if they're infected because of their challenges with treating people. And if the partner is infected, then we are going to treat the partner with the same treatment if possible as the partner. Next slide. Finally, I just want to mention prevention measures. We would prevent Mgen like other bacterial STIs using standard STI precautions, condoms, minimizing sexual partner number. Ideally, you want to be monogamous. There's no Mgen vaccine available, and to my knowledge, there's none in development right now. And then doxypep is something that many of you have heard about as a strategy to prevent bacterial STIs and those who are high risk. My personal opinion is that doxypep is unlikely to prevent or even clear existing M. genitalium infection because, again, doxycycline doesn't work well against M. genitalium. It grows very slowly and has a biofilm. So I think it's unlikely. If anything, it might just cause more resistance to M. genitalium. Next slide. So we're going to close out now. I'm going to turn it back over to my colleague, Dr. Stafford. She's going to tell you what happened with our patient that had persisting vaginal symptoms, negative chlamydia gonorrhea test, and wanted to get tested for M. genitalium. So take it away, Dr. Stafford.
Thank you, Dr. Geisler. So after hearing everything that Dr. Geisler said, we know now that traditionally we're not supposed to screen women for just plain first-time cervicitis, but the patient asked. So we tested her for M. genitalium, and her results were positive. So unfortunately, testing for macrolide resistance associated mutations was not available. And unfortunately, this is really the majority of the case right now. There are a few labs that do macrolide resistance testing, but again, hard to get. So she disclosed to her OBGYN that she and her partner are not currently using contraception. So the OBGYN orders a pregnancy test and it's positive. Next steps. Next slide. So again, we know from what Dr. Geisler said, and there's the CDC guidance does not recommend screening and treating for Mgen in pregnancy, even though there's some data, it is not strong enough at this point to say that it's a causal organism for any adverse pregnancy outcomes. So again, more data is needed there. But so we talk to the patient and we tell her about all of this. And after a shared decision approach, we talk about risks and benefits. She was given an extended azithromycin regimen because that's essentially all we could give her at this time. Okay. Her vaginal discharge improved, but did not resolve. A repeat Mgen test was positive. Again, there's no other further treatment options that we could give her at this time. So we just waited to treat her postpartum. So she had a normal term delivery and then was treated with doxy for 7 days, followed by moxifloxacin for 7 days, since that's all we have to offer for her at this time. Next slide. So in summary, genitalium is highly prevalent in clinic populations. In fact, in our population, we see it's almost 3 times more prevalent than gonorrhea and chlamydia and other STI. It can be asymptomatic, but can present with signs and symptoms, which can be associated with adverse reproductive and perinatal complications and increased HIV acquisition. Again, sexual health history is really important. Please talk to your patients, even if they're presenting with UTI symptoms, that they may in fact should be offered testing. We do recommend testing for Mgen using nucleic acid tests. We do have several FDA-approved testing options that Dr. Geiser presented. And because macrolide resistance is so highly prevalent, sequential therapy with doxy for 7 days followed by moxy should be used in non-pregnant persons when we do not have macrolide resistance testing available. And of course, pregnant women and those who cannot take moxifloxacin should receive azithromycin. Next slide. So thank you so much. We're going to hand it back over to Dr. Patel.
Thank you.
Thank you to Dr. Stafford and Geisler for that wonderful overview of Mycoplasma genitalium. I'm going to transition to the questions. So we've generated a lot of buzz over here. I'm going to start with the first question, which goes along access. If you're, in where I was in rural Missouri and at a STD public health clinic. The first question is to Dr. Stafford. Any recommendations for clinics without access to Mgen testing? And feel free to chime in, Dr. Geisler, as well.
Sure.
So to be honest, I think most places do have the ability, depending on what they're using for their test, if it's gonorrhea and chlamydia, it usually is with the aptima swab, or I haven't had any issues with testing in the clinical setting for genitalium. I have more of a physician provider knowledge base that they don't even know that it's associated with recurrent cervicitis in people. So to be honest, I think education is first and foremost for those clinical sites, even in the rural areas. And then, most clinical sites do. I think hospitals, on the other hand, may need a little update on genitalium, since a lot of PID patients, for example, present with nausea, vomiting, unable to tolerate PO, or have diabetes or some other comorbidity, and genitalium is not necessarily on the order set.
Yeah, and I can add to that, most major cities have big commercial labs like LabCorp, Quest, et cetera. Most of them actually have an Mgen test. And so if you're not sure about your clinic or hospital, you can reach out to the big kind of commercial labs in your area. If all else fails, we are actually happy to test it at our lab at UAB. If you simply just Google UAB Mycoplasma lab, you will find our website. There's instructions. You'll get very good customer service. You just send it to us. You can send it by mail, urine, et cetera. So that is an option as well. If you don't have any local options, you can send it to our lab.
Doctors, do you actually have this in your order set? I mean, this is important for us to start now normalizing, right? Awareness and being able to click a button and start to order it and start having clinical protocols. Can you tell us, do you have this? Do you have a clinical protocol at your clinic on this? And have you integrated this into your electronic health record?
Yeah, I can chime in quickly first. You can order it in any of our clinics, any of our hospitals. Basically, you can just look it up in our order system and pick up. It's pretty easy. As far as people knowing to order it, that is the challenge. I mean, so, some of the clinics that our program is engaged at, like the HIV clinic and the sexual health clinic, they all kind of know. But when you get into the hospital system, that's where, many don't know, like Dr. Stafford mentioned. So we try to give grand rounds and conferences and send information. And if you're at a place where you first develop a test in your order sets, I always recommend sending out an email and also faxes and all those things saying that, hey, we have this test here, it's recommended in. But despite that, sometimes people don't get the message. And so I think the problem is most people have a way that the test can be ordered, but do people know whether to order it or not? That is always kind of the challenge, I think.
And also, Dr. Geisler and everyone on this, a lot of people do not know how to manage results. Like, I would say that 3/4 of my calls about Mycoplasma are, oh my God, she's positive. What do I do now?
Mine are mostly, I tested an asymptomatic pregnant female for genitalium and she's positive. What do I do? And of course, I want to shake my head and go, well, you shouldn't have tested her because not only is she asymptomatic, she's pregnant, and it's not recommended to test them. I think a lot of providers, sometimes they just have a test they use for their clinic, and they don't realize that that test, all the different things it tests for. So genitalium is like bundled in this test, and then they get the results. Sometimes the patient gets it before they get it because it goes like in this patient portal, and the patient's like already calling the provider before they've even seen the result, right? And so I do think there needs to be a little more diligence that if you're a provider, you need to understand what's on the test that you're ordering. And there are STI test bundles that don't include genitalium, and those would be preferable for patients who are asymptomatic, because otherwise you're putting yourself in this bind. It's hard to educate patients on what to do because you have such little data for these asymptomatic patients, and these treatments like moxifloxacin can have side effects or risk in some people. So we don't take giving a asymptomatic person moxifloxacin lightly when they may not even need it.
And I want to build off this particular topic. One of the questions said, if we build this into the order set, do we also build in resistance testing as well?
That would be optimal. It is CDC recommended, that you do the macrolide resistance. The quinolone resistance right now, that is kind of a work in progress. I think most people know about this one PAR-C mutation. You can test for that, but that field is moving so quickly that literally our lab was basically about to launch a PAR-C quinolone resistance test, and then that gyre data just came out. And we're like, whoa, hold on, let's validate the gyre and add it to our test. And so I think for now, I definitely think it makes sense to add macrolide resistance tests, because we'd like to give macrolides when it's sensitive to it. But the quinolone, I think you have to be a little bit careful because we still don't fully understand which mutations are important, and that data is moving pretty quickly right now. So yes, macrolide resistance, but quinolone resistance probably not at this point.
And again, I mean, we just don't have an FDA-approved test yet. So that's a barrier. But I know that people are working hard on it, and that hopefully it'll be available soon.
Yeah,
that's what I'm getting, and I'm not going to lie, I tend to send samples either to Munson or to the guys regarding antibiotic.
Yeah, we can definitely test them in our lab. We're set to do the macrolide resistance, and we were almost set to do the quinolone resistance until we just pulled it back to incorporate gyre now. But we can do it if you want that. But we can do it within 7 days. But you may have somebody in your area that can do it if you ask some of the big labs too. It's possible.
Excellent. I have a question for Dr. Stafford, and then I've got two for Dr. Geisler.
Sure.
Dr. Stafford, there's a question in the chat about, are there other species of Mycoplasma in the lower genitourinary tract? And if so, is there a problem with cross-reactivity and then interpreting results?
I mean, I think I can speak a little bit to it, but I'm going to hand it over to Dr. Geisler. But I don't know that hominis, that any of the other molecules like ureaplasmas. Actually, ureaplasmas have been linked to some adverse pregnancy and neonatal outcome data, to be honest with you. And I think that should be a target of future research. But as far as the other mycoplasmas, no, I don't think they're pathogenic or have enough studies to show their association with that in adverse perinatal outcome or genital tract pathology. But definitely the ureaplasmas, I mean, that's definitely been a hot topic regarding perinatal. Well, Dr. Geisler, what do you think?
Yeah, that's pretty much correct. So there's Mycoplasma hominis and Ureaplasma parvum. Mm-hmm. Those two molecules are very common in the genital tract. And frankly, they're just part of the normal flora for many people. So we do not ever recommend testing people in the lower genital site for either Mycoplasma hominis or Ureaplasma parvum, because what happens is you give these patients results, then often they're really worried about it and they want to clear, and you try to treat something that's part of their normal flora. It keeps coming back. They get really frustrated. I get calls from patients who've been trying to treat for years, and they're all stressed out, and it's affecting their life and everything. And again, these bundled tests sometimes, these multiplex, will also include M. hominis and Ureaplasma parvum. It drives me nuts because they really shouldn't be in the test. Ureaplasma urolithicum, on the other hand, there is some data, as you mentioned, in the upper genital tract with pregnancy outcomes and in abscesses in the upper genital tract and some things like that. So I think if you had a complicated upper genital tract infection, testing for Ureaplasma urolithicum may have a place there, and certainly M. genitalium would as well. But for the most part, testing for M. hominis or U. parvum should simply not be done. So look at the tests that you're using in your patients to do STI testing, and don't use one that includes U. parvum or M. hominis, because it's just going to lead to difficulties with the patient management.
And I would say that cross-reactivity for the test is
Yeah,
not.
that's not a problem.
That's
The
not a
tests are
problem.
PCR based. They have very specific primers. There's
Yep.
not a cross-reactivity. Even culture, there's no issues for culturing. You can distinguish the bugs.
Excellent. This builds off again. There's a lot of questions wonderfully in the chat about routinizing and implementing what you've just spoken about, both of you. So this next question is about a PrEP clinic. So if for patients on PrEP, do you recommend Mgen testing with their quarterly STD lab testing as designated by the CDC for follow-up for PrEP clients? And then if you do recommend it in general, should we should we be doing 3-site testing, oropharynx, genital and rectal?
Yeah. Well, I guess I'll answer the first part of the question is that even individuals who are high risk who are on PrEP, if they're asymptomatic, I would not do asymptomatic screening for them. Again, because, it's a high risk population. Sometimes with these NAT tests, you can be measuring just an exposure. They may or may not even be infected. And then what are you going to treat them with? I mean, over 90% now mostly have macrolide resistance. You're going to start giving them moxifloxacin to treat them. Some are going to fail, and you're going to select more moxifloxacin resistant. So I definitely do not advocate routine asymptomatic screening, even in that doxy PrEP/PEP population. On the other hand, if somebody who is on doxy PrEP or PEP develops urethritis, symptomatic urethritis, certainly I would advocate for doing that as part of what CDC recommends, ruling out other STIs. And then if they have persisting urethritis, doing genitalium testing in that specific setting. And in women, again, women with persisting cervicitis, or if they're not getting pelvic exams done, they have persisting vaginal discharge, and you ruled out other things. Yeah, I think it's reasonable to do Mgen testing in those women, but not for asymptomatic. The second part of what you said, which I already forgot what it was. What was the second part of that?
The sites to test.
We
typically do 3-site testing for chlamydia and gonorrhea.
Yeah. I mean, so genitalium is actually fairly common in the rectal side as well. And there's not good studies associating genitalium with symptomatic proctitis, but there are studies showing that in men who have proctitis, genitalium is common. So my belief is that genitalium probably does contribute to symptomatic rectal infection. So again, I wouldn't screen individuals who are asymptomatic, but if somebody is having rectal symptoms, then I think it does make sense to do Mgen testing at that site as part of the routine diagnostic testing for the etiology. The oropharynx, kind of like chlamydia, you rarely find genitalium there. When it's there, they rarely have any kind of symptoms. We don't know if there's any clinical significance to genitalium being in the throat. So I would say, again, unless somebody's having throat symptoms, I would not do Mgen testing in their throat.
Excellent. This now the next question segues into doxy PEP, which you mentioned a little bit, but I wanted to. This is from the California Department of Public Health. The question is, what are your thoughts about STI PEP to combat Mgen?
Yeah, I mean, I think my thought is it's probably not going to combat Mgen. I think, STI PEP with doxy works very well against chlamydia, works very well against syphilis. There's not really resistance concerns with either of those organisms. It does also help with gonorrhea probably, but sometimes because of gonorrhea resistance to tetracyclines, it may not work quite as well. In the case of genitalium, this bacteria grows so slow, it's got this biofilm. Simply giving a dose of, say, 200 milligrams of doxycycline, a single dose, is not going to get rid of this organism. It simply is not sufficient. The duration of the drug is not going to be enough. But at the same time, because you're exposing just one single dose to this slow-growing organism with a biofilm, inevitably, I do think over time we're going to see a creep up in the doxycycline MICs. And so what that means is that as part of the strategic, sequential therapy, doxy may not lower that Mgen load as well as it used to, and then we might see more treatment failures with that second drug because we're trying to treat infection with a higher load now. So I'm really worried about it, but at the same time, I'm also practical. I know that chlamydia, gonorrhea, and syphilis are very important, that we need novel strategies to prevent them. And I think this doxy PEP is moving right along. I don't think it's going to stop because of this Mgen concern. But we just have to follow it, basically. We need to monitor for it. We have the surveillance program. We have specimens. We will have a way to kind of look at that. And so I think doxy PEP is going to happen. I don't think it's going to impact Mgen other than maybe selecting for more doxy increased MICs or resistance.
Thank you.
Yeah.
Well, we have many questions in the chat,
Okay.
and thank you to the audience for this wonderful, rich discussion. The IDSA Foundation organizers will be able to email the rest of the questions, the responses to these questions. And I'm going to go ahead and turn it over to Diane.
Great, thank you so much. The IDSA Foundation extends its appreciation to Drs. Stafford, Geisler, and Patel. Thank you to our audience for your attendance and participation in the active Q&A session. If you wish to revisit this webinar or share it with others, a recorded session will be made available on our website and YouTube channel. I also invite you to connect with us on social media. If you're interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit the IDSA website. ID Week will be taking place in Boston this year from October 11th to the 15th. There is still time to register. Tomorrow, September 8th, is the last day for early bird rates. We hope you will join us for our next webinar scheduled for Tuesday, September 26th at 1 p.m. Eastern, 10 a.m. Pacific time, focusing on the 2023 flu season. A registration link for that session has been provided in the chat. And finally, we kindly ask you to consider furthering your support of the IDSA Foundation with a personal donation. Your gift plays a pivotal role in advancing our mission of workforce development and making a tangible impact in the field. Thank you all again, and have a wonderful rest of your day.